Welcome. You are entering CCNA's studio in STEM City, USA. CCNA is committed to equity in education, social justice, and health. Today's CCNA studio session is focused on awareness of mental health issues facing our community today. To start us off, here is CCNA Executive Director Jim Page.
Greetings. I'm Jim Page from CCNA. And first of all, let me say welcome to the entire audience. Our mission at CCNA here in Alexandria is to focus on the issues of equity in health, education, and social justice. Today is the beginning of a series of workshops and webinars where we focus on mental health. Uh, in our community, mental health is a tough issue. I grew up in the South and we didn't talk about mental health, but now things have changed. COVID has forced us to look at things a little more closely. We're fortunate today to have some community stakeholders to join us and talk about the issue of community health. My takeaway for you is that we want to get the information out to the community, how you can be helped, where resources are and the things that we can do to help you become more informed, more inspired, and more supported. Let me take the opportunity now to introduce you to our health coordinator in CCNA, Dr. Andrea Hirsch. Andrea, over to you.
Thanks, Jim. Hi, folks. I'm Ann. I'm really happy to be here, and I thank you all for making the time to learn about one of the most important, but perhaps least understood aspects of our health, our mental health. Creating a psychologically safe community in which all of its members are thriving is a responsibility that each of us shares. In our first session of the series, our goal is to provide you with some very basic information on what the particular challenges look like, particularly in communities of color and for those who have been traditionally underserved. We're going to do a little bit of a change in our model today. Our first presenter, we are lucky enough to have Ms. Allie Walker, who will help us understand differences in mental health care utilization and address the historic and the ongoing myths and stigma surrounding this class of problem, as well as roadblocks to care. I'd love to have you introduce yourself, Allie, and proceed.
Sure. My name is Allie Walker. I am a practicing physician assistant, actually work in adult critical care medicine, but I'm also a suicide loss survivor and have been volunteering in mental health and suicide prevention for the past 12 years. I chair the board for the local chapter of the American Foundation for Suicide Prevention called the National Capital Area Chapter, and we serve Washington, D.C. and Northern Virginia. So it is a true pleasure to be able to talk with you all today about mental health and the role that stigma and various barriers to access influence on our communities.
Can we get started with your first slide, Allie?
Yep, I think this is perhaps Dr. Flanagan's slides. Perfect. So, mental health, as Andrea said, is a really common thing in our health. We all have mental health, but it's something that we often don't talk about. And so I think it's really great that we're having this conversation and can talk about the importance of mental health and what it means to take care of it. Right now, about 25% of Americans are living with a mental health condition. And in our lifetime, it's estimated that about half of us are going to face a mental health condition. So if that's the case, why is it that so many people are not receiving adequate mental health care? We can go ahead to the next slide. So I wanted to talk a little bit about some of the different barriers to mental health care, because I think there are kind of two facets to why people are not receiving mental health treatment. Part of that is a lack of interest for various reasons. And then part of that is also barriers in terms of an inability to access resources that are available. First and foremost is stigma. Stigma really revolves around having a negative attitude or reaction toward a person or thing based on their characteristics and behaviors. And in mental health, we know that stigma has been a really big issue. People have negative perceptions about seeking out care for their mental health or judging people for the behaviors that they're exhibiting. Traditionally, there's been misunderstanding, for example, about people living with depression and thinking that the lack of motivation or energy is related to that person as a character flaw, as opposed to a symptom of a disorder that's been untreated. There's a really interesting study done in the Netherlands that was looking at how does stigma actually impact the health of our community, and specifically in the world of suicide prevention, how does stigma impact suicide rates? And what they found is that in communities where there were more positive attitudes towards mental health care and towards seeking help, there were lower rates of stigma. They also saw that there is an association between individual feelings and attitudes toward mental health that are connected to the feelings and opinions of the community. So it's really important that we address stigma within our community because our attitudes impact the attitudes of others and also then therefore impact whether or not someone is going to seek out care. And in fact, stigma reduction is a cornerstone of suicide prevention. If you look at a number of very effective suicide prevention strategies that have been implemented, including the study I referenced in Knox et al., suicide prevention really does depend heavily on stigma reduction. Financial access is another really important facet to barriers to accessing mental health care. And this is really speaking to people who probably want to access mental health care services, but are not able to based on resource limitations. If you all remember back in 2008, this was just prior to the Affordable Care Act, the federal government passed a law called the Mental Health Parity and Addiction Equity Act. And the intention behind this legislation was to improve parity between mental and physical health. And what parity is talking about is the ability to access services and limiting any disproportionate barriers that might be imposed on mental health services. So it should not, in practice, be more expensive or more difficult to access mental health treatment. But unfortunately, a review that was just published looking at enforcement and compliance of this mental health parity has shown that there's significant inconsistencies across the United States. Additionally, telehealth services have been a really great strategy to try to combat some of these barriers that we know about, both physical barriers and also financial. However, getting coverage from reimbursement from insurance companies to cover telehealth services for psychiatric care has been a challenge. So financial access is certainly a major issue. And one of the things that we can all be doing about this is becoming more active in our advocacy efforts. There are a number of pending federal bills that have been proposed that would actually address these issues. So, for example, there's one bill that would allow the Department of Labor the ability to enforce group health plans that are not compliant with health parity. And there are other bills that would expand insurance coverage and access for telehealth services for mental health care. Lack of awareness of resources is another important barrier that we need to talk about. I can't tell you how often I hear from people who are reaching out saying, hey, I know so-and-so who's really struggling with their mental health, or I am personally really struggling with my mental health, but I don't know where to go to get help. And this is an opportunity where talking about mental health very openly and educating ourselves about this as a health issue becomes so important, because we need to raise awareness in the community that mental health conditions are treatable and that there are resources available, but sometimes navigating that is challenging. And one of the best pieces of advice that I will give to all of you that are watching is to talk with your primary care doctor. Sometimes finding behavioral health specialists can be challenging. Like I was just talking about, financial access can be a challenge. And getting on a wait list that's going to take you a couple of months to make an appointment can be difficult. But your primary care provider can often be well equipped to care for many of the common mental health conditions that people are living with. And they're also often great resources to help direct you to services that you're looking for. And finally, distrust. And I think distrust comes into play particularly in the BIPOC community. People of color have a long history of distrust with the medical enterprise, and for very good reason. And so it's extremely important that as a community, we work together to build mental health services that provide culturally competent care, and that we have mental health clinicians and other health providers who are um, people of color and who understand the community that they serve, and understand the unique cultural beliefs and religious beliefs that different people hold, and how those beliefs impact their behaviors and their perceptions of mental health care. And then I included the Americans with Disabilities Act here as well, because as a clinician, I belong to a community that also has a lot of distrust about disclosing difficulty with mental health conditions and about seeking care because of the concern of retribution towards our career. And it is illegal for employers to be asking questions about the history of your mental health conditions when they hold no bearing on your job performance. And what's very fascinating to me is how many states have licensure questions asking clinicians about their mental health history, and are in direct violation of the Americans with Disabilities Act. So I think it's also important that people are familiar with their rights and what things are okay and what things are not okay to be asked by your employers and other people that have influence on your life. So, I think there are a number of barriers that we could talk about, but I wanted to center around these four because I think that they hold a lot of influence on the way that people approach mental health and mental health treatment, and prevent people from accessing the care that they need and deserve.
Thanks, Allie, very much. I have a comment. As far as I understand it, about 50%, perhaps a little bit less, who admit that they need help don't get it. And in communities of color, that number is almost halved yet again. Can you speak specifically? I know that in the African American population, I believe that maybe 29% of people that acknowledge mental health needs don't follow up with service. Apparently, it is quite low in populations, Hispanic populations. Least so the case in the AAPI community. But can you just clarify again what you see as the primary roadblocks in these patients?
Yeah, I mean, I think there are several, and I think every individual and every community faces different unique barriers, right? I do think that stigma is a big barrier, and that's why I talked about that first. I think that there is a lack of community education, and I don't think that's unique to the BIPOC community. I think in general, there's a lack of education around mental health and distinguishing the difference between a person's chosen behaviors and exhibiting mental health condition symptoms. But I think the other thing is a reputation within a community around what it means to seek out mental health care. And, I have heard from a lot of people in the Black community, for example, who talk about their strong ties to faith and the way that faith leaders have influenced their feelings and attitudes towards mental health care. And that often advice from faith leaders may be to spend more time praying and to spend more time going to church and leaning on their faith as a solution. And I think that it's important to understand that um, faith can certainly ground us and give us values and a purpose in our lives. And that can be extremely helpful when we're struggling with our mental health. But it's also about combining our faith with medical treatment because mental health is a facet of our health. So I do think that's important. And again, going back to distrust, there's a long history within medicine of um, unethical experimentation and treatment on patients who are belonging to minority groups. And I think that that has also created a lot of hesitancy around people seeking help when they need it and questioning whether or not they're going to receive the care that they really are looking for.
Okay. If you could give us, and I think you've already stated them, Jim, do you want to ask the?
Yeah, I've got a quick question. Ali, thank you. Thank you for the presentation. Ali, you mentioned telehealth and the difficulty with that. What do we do about bandwidth and having the infrastructure to deliver telehealth? I know that's not a
I
medical
think,
issue. Go ahead.
yeah, I mean, I think that's a great question. And I think that's something that has to be looked at. Because again, barriers to healthcare look so many ways. Financial access doesn't only include insurance coverage, but it's also whether or not you have transportation, whether or not you can take time away from your job, whether you can afford to fill your prescription. So there are so many different facets to access that we have to think about. And so certainly when we're talking about telehealth, we also need to understand, are our patients able to access the internet and are able then to engage in telehealth services? So I think that's a great question, and again, an opportunity to become an advocate in our community and understand where are there gaps in that infrastructure and how can we use our voices to advocate for more infrastructure spending to boost those services.
Yeah.
Right.
Thank you. Andrea, Dr. Flanagan has joined us. We might want to bring her in as soon as we can.
Okay. Can do.
Ali, thanks a lot.
Thank you, Al. Dr. Flanagan, Karen Flanagan is here to give us a basic overview of prevalence of mental health problems in the community. And we thought that would be rather eye-opening. I think it's fairly close to our hearts in the city of Alexandria. So if you would briefly introduce yourself, Dr. Flanagan, and let us know when you're ready for your first slide.
Sure. Well, I was going to say good morning, but the day is just flying by. So good afternoon. Thank you so much for inviting me to be a part of this important conversation. May is Mental Health Month, but honestly, we need to be talking about mental health every day of the week. I'm so excited to be here to be able to share some information. And I just have to give a shout out to Ali. What great information to be able to share from a cultural competency lens, and just really appreciate being able to come after her great feedback. So would love to show you what is mental health by the numbers. So unfortunately, I got the dry information, I got the stats, but I'm going to really put a shout out to our NAMI partners who gave us, and you can find this on their website, but has a great informatics around mental health and what it looks like in the state of Virginia. So if you go to the next slide. So again, this is a great informatics, not surprising, but we have about 1 in 5 adults, not kids, 1 in 5 adults live with a serious mental illness. So we're not just talking about a low-level depression from an adjustment in your life. We're talking about a serious mental illness, someone that needs to have follow-up, consistent follow-up by a provider. So in the state of Virginia, we see that really comes to around over 1 million, 1.2 million adults in the state of Virginia that we know have a mental health condition. And that as we look at that, we see the following pop up where the population is that we're seeing the greatest from Charlottesville and Richmond. Thinking about children, adolescents, right? So Ali was talking about how important mental health care is. It is as important, if not more important, than our physical health care. But there's all those stereotypes and stigma surrounding mental health. And again, we're breaking that down today by having this conversation, listening to understand and having questions asked. But looking at our children, it shows that we have an estimated, because it's very challenging to get, exact data, but around 85,000 to around over 104,000, we believe, children, adolescents that are having and living with mental illness. And what we're not sure of, how many are also getting treated. We look here to be able to say that the average onset of mental health symptoms can start around 8 to 10 years. And again, when we are thinking about communities of color that are not necessarily having the same access to treatment as people that look like me, then that can be even more prevalent. So that's why it's important to have culturally competent providers in the mental health world as well, to help increase people's comfort level and to decrease that mistrust. We have here I thought this was interesting. In 2020, Virginia ranked 42nd out of 51 in terms of ease of access for mental health care. That's not the number that we would really like to be, for sure. As vice president of the behavioral health service line for Inova Health System, it is critical. It is a part of my everyday conversation to increase access. How do we ensure that we're increasing timely access? Something similar to what Ali was saying, there are wait lists, but what can we do to be able to make it easier for our community to increase the access that we need? So again, it's disappointing that we're 42nd, but again, from our perspective locally here in Fairfax, Alexandria, and the Northern Virginia area, really looking to continue to work on that, because that is a part of our everyday conversation. We are seeing deaths of suicide increase significantly, and we're really also seeing that as part of that post-COVID world. Also part of the post-world of murder of George Floyd, that has really increased the feeling of increase of depression, symptoms of anxiety. So that is something that we're seeing in our emergency rooms. People are walking to their emergency rooms because they do not know where to go. So again, just want to continue to advocate. It is really critical that we be talking to one another, utilizing our providers that you have an already established relationship with, which are your primary care physician or practitioner. That last one there that we saw, we have 15.7% of high school students and 21.4 middle school students that have been reported to attempting or considering to attempt suicide, meaning that they've had some suicidal thoughts. So we do know that there has been an increase of attention in our school systems. Again, that's why it's so important that we work collectively. It is everybody's responsibility when you see something, say something, and to be working collectively to be able to support community of all ages. Can we go to the next slide? All right. So here we have some information. A couple of points that I would like to bring out is that if you look down to the bottom lower square, we have around a considerable amount of people that are living in Virginia. However, we definitely have a mental health professional shortage. We had one before the pandemic of COVID, and we are definitely having access issues. I'm not sure I can say post-COVID, but at this point in time in 2022. So it's definitely facing a challenge there of finding mental health professionals. And in addition to that, also ensuring that when we're bringing mental health professionals on, we are bringing on individuals, clinicians that are culturally competent, that look like the community that we serve, which is very critical. We know that depression is the #1 leading cause of disability. This has occurred significantly across the nation. Coming back from California, that was the #1 cause there. And if you see that over $193.2 billion of lost earnings are due to depression and disability. Can you imagine what we could do with that type of money to be able to put back into our mental health care and support within the community? Also, I think another big number there is that 155.7 billion a year, and that really speaks to individuals that are diagnosed and suffer with schizophrenia, and this usually develops early in life, and that's the cost that is estimated to be able to that is lost for those individuals. Something that is near and dear to my heart is that we know that many people that have mental illness do not get treatment, and instead they get triaged to jail because there's sometimes lack of awareness and understanding. So again, there is a great jail diversion program here in Northern Virginia that is working really hard to be ensured that individuals of our community get the right level of care, appropriate level of care for their mental health. And it says 1 out of every emergency department visits involves a mental health or substance abuse condition. I can tell you that that is absolutely true. And I would bet if we did new data today, that it would be much, much lower than that. Definitely much, much lower than that, because we have seen an increase due to COVID for substance use, an increase of anxiety with what is going on in the world today. And I know, today we're talking about the shootings in Texas, and that absolutely affects all ages, our parents, grandparents, our children, and those symptoms are definitely there. And how do we have well-being? How do we work with that? So definitely when we think about mental health by the numbers, it definitely has an impact on us as individuals, as people, on healthcare providers, also financially, of the cost when we don't do anything about it. And more importantly, the cost on the life and the living of fullness, a full life of individuals that are suffering without help for their mental well-being. So again, I know we're on a timeline. So those, I think, are our 2 most important slides, and definitely be open to a question or so that you might have.
Thank you. Are there any questions? I don't see anything coming across the screen at this time. Jim, do you want to ask the famous question?
Hey, Dr. Flanagan, thank you so much for joining us. What part of Boston or Australia are you from?
Jim, you are now the light of my life. So definitely not Boston, but you are right on with Australia. I'm from Brisbane, Australia, born and raised by way of California. And now I am here in the Northern Virginia area. So happy to be here.
And welcome home. A couple of questions for you. One, you mentioned lack of clinicians. That is a problem. What are your suggestions? How do we get more professionals like you and Dr. Hirsch and Ali into the profession?
Well, that's a really good question. So I think my recommendations on that is that we need to think differently. The former ways that we used to use pre-pandemic just are not working anymore. And so I would say, from my perspective, what I'm looking to do here at Inova is we need to create the pipeline, meaning we need to be able to not only connecting with universities, but I want to make sure we're getting with our historically Black colleges and universities. Go Pine Bluff. But we need to be in the community talking to our middle schoolers, our high schoolers. It really starts with there, planting the seeds, making sure we're speaking to them. It's not about just doctors and lawyers, but lots of different types of mental health clinicians, and there's lots of different types of physicians at all levels to be able to have these young people think about of how they may be of service in careers that they would like to do. And it starts with having intern programs, going into the schools. Let's meet people where they're at, and as well having them come into our hospitals in the summer and have some programs and showing them what healthcare is and how they could be a part of it.
Right. Oh, the other thing too, if you could join us to meet with several family members, would you be willing to do that, to talk about the family approach to mental health?
Absolutely, I would love to do that.
I'm gonna put this down and hold you to that now, along with you and Ali.
Hold me to it. I'm in.
Yeah, great. The last thing is, Inova has a Dream Big program that looks for the next rendition of conditions. Are you familiar with that?
I am still new to Inova, but I am definitely connecting with Duran on how we can work together from a behavioral health service line.
Again, thank you so much for joining us.
Happy to be here. And thank you and again, Andrea, thank you so much for putting this together, because the only way we fight stigma and the stereotypes of mental health is having these conversations. So I appreciate the invitation.
Karen, there are a bunch of questions in the chat. We can't get to them, but I'm going to circle back with you, with Dr. Hirsch and the rest of the panel members. Again, thank you. Andrea, back to you.
I love it.
Thank you very much. It is my pleasure to introduce our next speaker, Ms. Nurain Buttar. She's here to describe the way in which various life stressors or potential traumatic events that are ever present in our community, how they can have a profound effect on one's ability to thrive. Understanding impact of these kinds of stressors and what the effects may look like is really our step in bringing about or helping with the healing. So if you'd be so kind, Nurain, to introduce yourself and let us know and share with us the information you have.
Thank you. And thank you to CCNA for inviting me. So I'm Nurain Buttar. I'm the Chief of Youth Development here for the City of Alexandria and the Department of Community and Human Services. And we focus mostly on prevention. And so I'm going to talk today a little bit about trauma. Just to give a sort of disclaimer in the beginning, this is a heavy topic. So please do what you need to take care of yourself. All right. So this is just going to be a sort of a brief overview, and then hopefully I'll be able to direct you to other places if you want to get more training or information about this topic. So if you look at our next slide, we should probably start off with a shared definition of trauma. So we like to go with SAMHSA, which is Substance Use Mental Health Services Administration definition, because it was great in 2014, still fits today. So individual trauma results from series of events or set of circumstances that is experienced by an individual as physically or emotionally harmful or life-threatening, and that has lasting adverse effects on the individual's functioning in mental, physical, social, emotional, or spiritual well-being. So that's a mouthful. What does that actually look like? So on the next slide, we have some potentially traumatic events. So it could be physical or sexual abuse or assault, emotional abuse, physical or emotional neglect, medical trauma. This could be botched surgery. This could be just receiving bad care, forced displacement. A lot of times refugees, but right now we're probably thinking of Afghan refugees, Ukrainian refugees, terrorism or war. Bullying can be very traumatic for people. Any type of an accident, natural or man-made disasters, attachment disruption. You see this often in young children who are taken away from their primary caregivers at an early age. Community or intimate partner violence. Poverty can be very traumatic, homelessness, and then racial trauma. And we'll go a little bit more into racial trauma a little bit later in the presentation. So next, if we go to our next slide, I'd like to talk a little bit about ACEs, because it comes up a lot. Everybody wants to talk about adverse childhood experiences now. Now, I will say these first couple of slides are probably going to be a little bit of a downer, but I want you to know I'm going to end on an uplifting note. So if you'll stay with me till the end, you'll see some light at the end of the tunnel. So the ACEs study was a snapshot in time. It was a national study. It was 17,000 adults, and they surveyed them to see what adverse childhood experiences they were exposed to. And so they were looking at emotional abuse, physical abuse, sexual abuse, emotional neglect, physical neglect. The mother was treated violently, household substance abuse, household mental illness, and then if the parents were separated or divorced. And what they found was over 60% of children are exposed to some type of adverse childhood experience. And more than 1 in 5 is exposed to 3 or more adverse childhood experiences. So why does this matter? So if we look at the diagram on the next slide, it's showing how adverse childhood experiences will negatively or could negatively impact a person's life. Now, I want to say, we'll talk about more about this later, but this is not a self-fulfilling prophecy. It doesn't mean, well, I've got my A score. This means that these are all of the negative impacts that are going to happen to me throughout my life. All right. So I just want to put that in there first before we go over these. So the more you have, the more negative outcomes you could have. So a person with an A score of 6 or more can have a 20-year shorter lifespan than a person who doesn't have an A score. ACEs are really common. Like we said, 2/3 of adults have at least one. Childhood adversity contributes to most of the chronic health issues we see now, mental health issues, economic and social health issues. So if you look at this diagram, we start with disrupted neurodevelopment. This is where you see kids having problems in school, social, emotional, and cognitive impairment, health risk behavior. These are things like substance use disorders, having unprotected sex, or engaging in other risky behaviors that could cause harm to yourself, diseases, disabilities, and other social problems. And finally, the one that we mentioned, sort of the most serious, which is early death. So what does this look like? Well, if we look at our next slide, this can be internalized beliefs that where children and adults who've experienced a lot of adverse childhood experiences can have this view where everything bad that's happening is my fault, that they blame themselves for the negative things that have happened to them. They can also be very pessimistic. They feel like, there's a negative worldview that there are no good things happening in the world. There are only bad things. They don't feel safe in this world. They tend to have fear and anxiety. So things that someone with as lower or no A score might think, well, this is a little concerning, but I'm not that worried. Someone who has a higher A score might immediately jump to fear. They have a hard time trusting others. They might even perceive caring adults as a threat, because if they've had other adults in their life who treated them poorly and caused some of these A scores, they may not trust the ones who come into their life later. A diminished sense of personal safety. They could have really difficulty managing emotions and stress. So these are the people you could see where you're like, man, they seem to get angry really quickly and I don't know why. They don't seem to get past this stress response of freeze, fight, or flight. There are certain situations where all of us would sort of jump to one of those, but they tend to react this way in situations that you would think, this isn't that serious. Like, this isn't something that we should be that upset about, but they might jump to that immediately. And a type of person might come across as argumentative to you, and you can't understand why it is they're seeming to be upset about something that you don't feel like is that big a deal. They could be poor problem solvers. They have learning and memory issues, so it's really hard for them to sort of engage in critical thinking. They could have sensory issues. If you know someone who doesn't want to be touched, doesn't like loud noises, delayed adaptive development is what you can see a lot if they've had it really early in life. And so children are supposed to sort of hit general milestones as they age. And if you notice they're not hitting those milestones, some of that could be caused by adverse childhood experiences. Now, notice I'm saying could be, because the last thing we want to do is sort of label children and say, well, this behavior must mean there was an adverse childhood experience. So if you look at these taken together is what we're trying to do. They have a lot of peer conflicts, and they have a problem maintaining healthy relationships, because if you think about it, if you've had trauma early in life, and this is what you've learned from an early age, it's very difficult later to form healthy relationships when you haven't seen healthy relationships or you've experienced violence in relationships. And we already had talked about some of the high-risk problematic behaviors, such as the substance use disorder, the having unprotected sex. So if we look at the next slide, we can see, what does a child's brain look like that's had extreme neglect? So if you see on the left, the normal brain, that's a healthy brain, no adverse childhood experiences. And then you look at the right, you can notice it's a lot smaller and the dark areas are a lot bigger. So what does that mean in reality? We see the picture looks concerning. So if we look at the next slide, this is the hurt child's brain. And it's a brain that's operating at a level of survival all the time. And so this child is always, and this can happen when they grow into adulthood, where they're always worried about sort of just the basics. If you imagine A lot of us learned about Maslow's hierarchy when we were younger, and at the bottom of this triangle is food, shelter, and they sort of get stuck there. They never get past that level of, I just need to do the things to survive, which means they're not going to be able to reach greater outcomes because they're stuck at that stage. Their behavior is triggered by this child sense of fear, and this happens even when they grow older. And this is where I'd really like to plug Dr. Bruce Perry's book. He wrote a book with Oprah, and it's titled "What Happened to You?" And it's a shift in thinking where, if you see a child misbehaving, the question that usually comes up is, what is that? Like, what is wrong with that kid? Why are they doing that? And instead, we need to change to what happened to you? What happened to that child? What happened in their life that this is how they are reacting? And so we also want to shift the thinking of this child is being willfully obedient. They're not listening. They don't care. And, this is something that the ACEs is something that we're trying to get out into the community and that we're doing a lot of trainings about, because we want anybody who works with youth, anybody who comes across kids to understand this, that some of these outbursts are based on this child's fear and adverse childhood experiences had. There were some of these teens outbursts or even some of these adults outbursts. And if we know these things, then we can react differently ourselves. So as I mentioned earlier, I wanted to touch base or go back to racial trauma. So if you look at our next slide, trauma intersects in so many different ways with culture, with history, race, gender, location, language, and we really need to form trauma-informed systems that understand that the compounding impact of all of these, the impact of structural inequity, and that we need to form systems that are really responsive to the needs of our diverse communities, and especially here in Alexandria where we are so diverse. So in order to understand these increasing needs and the standards of care for traumatized children, we really need to understand the populations that we're working with and what their religion, their culture, so that we're providing the kind of care that's supportive to them. We also need to work on eliminating disparities. I think the two speakers before me talked about that a lot, and I really appreciate it. And we want to work to reduce barriers to care, to overcome stigma. Before it was mentioned about some of the stigma specifically in the BIPOC community. This also holds with refugee communities. Sometimes they're coming to us from a population that doesn't talk a lot about mental health or finds mental illness embarrassing and it's not something you talk about. And so if we want to really strengthen families and we want to encourage positive ethnic identity, we have to first study these things so we understand it and so we can actually support people. So that's sort of the I call it the quick and dirty on trauma. But what I really want to focus on and what I hope you'll remember is the uplifting positive piece. So what can we do as a community keeping all of these things in mind? Well, resilience. We can teach resilience. What is resilience? The ability to recover from traumatic events. What are the things that increase resilience? Well, one of the biggest is a relationship with a competent, caring individual. So if we can put people in children's lives that care, and this could be teachers, this could be coaches, this could be neighbors, just anyone who is supportive and they know they can count on this person, that greatly increases their chances of positive outcomes. I saw a question pop up earlier about, well, are we screening for ACEs? And I think what's really important to remember is that we don't use these ACE scores as predictors and say, well, let's go find the kids that just have the ACEs, and then these are the ones that we need to support. We need to support all children, because if we now know that ACEs are so prevalent in the community, then we know there's a certain way that we should be supporting children, that we should be positive role models, we should be mentors. And I say we because I'm talking about all adults who have some connection to youth, which I'm hoping is pretty much all adults in the community. We should really nurture their talents and abilities. There's something called developmental assets, which we teach in the community, and these are building blocks to build healthy youth. And there's 20 internal assets, 20 external assets. These are about self-esteem, about the community valuing youth. And if all of us collectively work on building these 40 assets, that would encourage so much resilience among youth, and it would decrease the negative factors I talked about, some of the risky behaviors, and increase positive behaviors. So we call these talents and abilities in the developmental assets words, we call them sparks. And so you find out what a child is into. Do they love to read? Do they love to paint? And then you nurture that. You nurture their spark. And that's one way to really build happy, healthy children that turn into happy, healthy adults. You also hand over control to them. You give them decision-making power. We don't always have to tell people what they need. We first should be asking them, what do they need? What could they use some help with? And then we provide the resources, but we also create the conditions for them to thrive. So you can't just, say, oh, well, somebody needs food. Let's just hand them a SNAP debit card. There, now they have food. What else is going on in their life? How else can we support this family? Because we want to think of it as sort of the holistic approach and not just this piecemeal. We can solve for one issue and we're not sort of considering the totality of what they're going through. And that's why I like to end it with one of the biggest factors in building resilience is having a sense of belonging to a community, group, or cause larger than oneself. And I just really want to thank CCNA because I think this is something that you really tend to highlight is you gather people around a specific cause and then you talk solutions. And so this is going to be my plug for RAISE. RAISE is Alexandria's Trauma-Informed Community Network. It stands for Resilience Alexandria, Inform, Support, Elevate. I encourage everyone to join this network so you can get all of the resources and really learn some of the different strategies if you want to be able to support people in your community. And with that, I will turn it back over to CCNA. And this is my contact information if you'd like to reach out to me about anything I just talked about.
Oh, thank you so much. Thank you so much. Seems, Narain, you've an action item, and that is that we'll find RAAE. I think what's most striking about your presentation is that it really to the mandate CCNA, which is looking at the person, not just their mental health issue, but recognize how struggles with medical health, with quality of it, all combined, to name a few, in determining well-being. So thank you.
Hey, Lorraine, Andre, may I?
Yes, you may.
Lorraine, thanks. Thanks a lot. A couple of things for you. One, you mentioned RAISE. I am a member of RAISE. I'm very familiar with it. So congratulations. I've got a couple of admin points. Can you talk to us very briefly about the intersection between the CHIP, the Youth Master Plan, and ACS's plan, how they all kind of work together?
Yes, absolutely. So, and I'm hoping you're referring to the press release that people will reference that recently went out. So there's three major plans in the city. Well, there's a lot of plans in the city, but there's three major plans that impact youth. So there's the Community Health Improvement Plan, and that's through the Partnership for Healthier Alexandria and the Health Department. There's the Children and Youth Community Plan, and that's under the Department of Community and Human Services and the Children, Youth, and Families Collaborative Commission. And then there's ACPS's Alexandria City Public Schools 2025 Strategic Plan. And there are certain strategies among those plans that overlap and they impact the children and youth in Alexandria. And so we formed a group called the Unified Implementation Team. And this team is looking at these strategies, ensuring they're aligned, and the strategy and the actions that we're carrying out are also aligned. And we'll be reporting out on them twice a year to let the community know, here's where we are, and here's where we're going with these strategies. So
Great.
Thank you for giving me a chance to plug yet something else.
No, you sent me a check to do that, so I'll take the check. One thing, this is off script, not part of the program, but Dr. Hirsch has joined us recently as our medical professional. Andre, I wanted to take the time now to thank you personally for bringing everybody together. Any personal thoughts before I go to the next question? Any personal thoughts from you?
I am delighted to be here. I so appreciate the power of the strong relationships that we have with different agencies and services and members of the community.
Okay, thank you. Welcome aboard. This question is for all of our panelists, and don't everybody jump on this. But when we look at what we can do better in the community, give it some thought, and I'll go to each one of you. I'll start with you, Narain. What's the one thing we could do better?
I would say raise awareness, and this is a sort of, I keep making plugs, I feel like, but if you're better educated, you can help others. And so please take an ACEs training, take a developmental assets training, take a youth mental health first aid, but educate yourself better on the topic so you can support others.
Great. Can we bring Ali back on screen? Ollie, what about you? What's the two things you could do better?
Um, well, I think one really simple change that we can all be making is our language, the way that we talk about mental health. Because when we think about stigma, um, there's perceived stigma, which is how we observe the behaviors and attitudes of other people towards mental health. And so something simple like changing the way that we talk about mental health can have a really big impact on how other people feel about their comfort with seeking help. And also with having conversations that are caring with people that they know and trust. So using appropriate terminology, not conflating mental health conditions with insults in like casual conversations, saying things like died by suicide as opposed to committed suicide, which suggests that somebody has committed a crime. And actually, in the Commonwealth of Virginia, it still is considered a crime, common law crime to die by suicide. So I think language is really important. And I will tack on a shameless plug with Noreen here and talking about education, because the American Foundation for Suicide Prevention, that's really a cornerstone of what we do. We provide services for people who've experienced a suicide loss, but we also provide a ton of education to help our community better understand mental health and suicide prevention and the role that each person can play, because it's not only in the hands of our experts. It really is up to all of us to work together. So if you go to afsp.org/NCAC or just afsp.org, you can find all of those resources.
Shameless plug. Shameless plug.
Shameless plug. Can't help it.
Is Dr. Flanagan still with us, or has she departed?
I think she's departed. Yeah.
Let me come back to Noreen then. Noreen, you mentioned Maslow and the hierarchy of needs, and we grew up in grad school believing that to be the end all end. Is that still true now? Is that still a model that you support?
I don't think, in the sense that, like, I don't think it's really studied as much anymore. Now I think it's more used as a just a framework. Like, okay, if this is Maslow's hierarchy, how do we get people?
Right.
Like, how do we create the conditions to get to that self-actualization piece? I think it's more so in that sense, at least for when I refer to it.
Great. The other issue we had, though, with the Community Health Improvement Plan, Noreen, you're part of that. Is there a mentorship component in there? If it is it aggressive enough in your opinion?
So, yes, I'm part of the Community Health Improvement Plan. I get to chair the mental health literacy work group.
Right.
I believe there is, I'm more familiar with it in the children and youth community plan, but there is an Alexandria mentoring program here in the city of Alexandria. It's housed under the court services unit. And so there is over like 10 to 15 mentoring programs where volunteers can sign up to become mentors, and they range in how many hours are required and sort of what's required and how you interact with the youth.
This is a shameless plug for CCNA. One of the things we try to do is get all the right people in the room together to talk about issues. There's a young man who's running a mentoring program here. I talked to him over the weekend. He wasn't even aware of the Community Health Improvement Plan. So from my perspective, one of the things that we can do in the other nonprofits is to bring people into the room, put them around the table, and listen to what Ollie has to say, what you have to say, and then trying to bring it together. I'm going to close with a couple of thoughts, and then I'll turn it over to Andrea. I think this city is working hard to address the issue of mental health and health. COVID came 2 years ago and just slapped us in the face, but I think it was a wake-up call for the community. I think Health and Human Services, the health department, the chief of police, we're all trying to do the right thing, but it's a struggle. So my plea for you and other stakeholders is every time we get a chance to share a word or to affect the life of one family, one kid, one young guy down on Braddock Road, take the time to do it. Put your hands on his shoulder. I was talking to my granddaughter last night about the shooting in Texas. Today's her last day of school. And she said, people, I don't know. I'm not scared to go to school. This is an issue that is not just in Alexandria, it's across the nation. And I think if people know that Alexandria is doing a good job, Arlington would be better off. So would Fairfax County. So I want to thank each of you for joining us today. There are a whole bunch of questions in the chat room. The one I will give you is from my good friend, General Bowman, who he and I work on suicide prevention for military. He wants to know, why is suicide such a prevalent issue for military folk? Ali, you have any idea about that?
Yeah, I mean, I think there are a number of risk factors that are particularly unique in that community. I think one is our traditional expectation of what it means to be a military person, which is to exude strength and courage. And I think stigma has kind of instilled this thought that struggling with your mental health means that you are in some way weak. And that's a myth that we need to dispel. We need to teach people that seeking help is a sign of courage and is a sign of strength, because we all are experiencing mental health on a constant basis, and sometimes we're in a bad place, and that's when we really need to be reaching out. I think there's also, culturally a lot of concern. I talked before about the Americans with Disabilities Act and how, understanding your rights as a citizen is important, and knowing what your employers can and cannot ask of you, and how, your employment might be affected by mental health conditions. And I think in the military, that's a big concern, particularly if you're somebody who works in combat, where it may mean working with your supervisors to change the type of work that you're doing while you're in treatment until you reached recovery. So I think those are, there are a number, but I think those are two big ones. And then, Noreen was talking earlier about trauma, and, the exposure to trauma. And also access. When we talk about suicide prevention, this goes for everybody. Limiting access to means is extremely important. That means we're restricting a person's ability to access whatever means they're going to use to try to take their life. And military people are one of those groups of people that may have disproportionate access to lethal means like firearms.
Great. One thing we did not talk about to both of you was COVID, the effect of COVID on mental health. I know you have some thoughts about that, Noreen.
Just that now I'll limit this to youth because that's who we've seen the most. That it has, we've all seen the news articles. It has impacted them the worst, I think, when it comes to mental health, because these are people that are used to being social, at least within like a school environment. And so going virtual for the majority of them, it had a harmful effect on their mental health. And so we are seeing that now. And we are, when you're dealing with, it's traumatic anyway, COVID, and watching people close to you either get it and get very sick or die. But then when you couple that with feeling isolated and not being able to connect with people you're used to connecting with, we've had to learn other ways to engage, but especially when it comes to youth, I don't think doing it over a computer was the same for them as doing it in person.
Right. Holly, any thoughts?
Yeah, it's interesting. The CDC did household survey, pulse surveys throughout the pandemic to assess what the state of mental health was in the community and how, COVID was impacting that. And what we saw was a tremendous increase in symptoms of distress. These surveys can't diagnose you with a certain disorder, but they can detect whether you're experiencing symptoms of depression or a lot of anxiety. And so we saw that those symptoms definitely increased significantly. What's important is that we did not see an increase in suicide deaths. In fact, we have seen a consistent drop in suicide deaths since 2019, which is really good news for suicide prevention, and also is an important flag for us in the community that while we're experiencing a lot more symptoms of distress, if we continue to keep the channels of conversation open and continue to connect people to the resources that we can make available, we can prevent people's symptoms from getting to the point where it actually costs them their life.
Great. Andrea, you still with us? Dr. Hirsch? Andrea? Can you bring Andrea back, Jackie, please? Guys, please bring Dr. Hirsch back on the screen. I guess they can't hear me. But anyhow, we're going to close in a couple of minutes with to sum it up with resources. Is this, Andrea, is this you?
It looks like Dr. Hirsch dropped off, but these are some resources that I think she compiled. So Child and Behavioral Health, Family Health Services, this is actually under the Department of Community and Human Services, the department I'm in, so that's a phone number. They have Adult Behavioral Health Services. And then Dr. Robin Mellenbeck is with George Mason University Center for Psychological Services, and she's the one who introduced us to this emotional support line that we've really been pushing out because it's free, it's confidential, and it's for all ages. And then, of course, the Suicide Prevention Lifeline.
Okay. Great. We've got about 57 seconds. I'm going to close with this. First, I'm going to say thank you again to everybody for joining us. and to remind you that this is the beginning of a series of workshops around the issue of the journey toward equity in social justice, education, and health. This is just the beginning. You have a standing invitation to join us at any time. So I'll close with thanking you and welcoming you to the studio at any time. So with that, we'll say greetings and see you later. Take care.